Hey, this is Pushing Glass from Coast to Coast. You sent to us, we diagnose. Make sure you like and subscribe. For this presentation, we'll talk about the nuts and bolts of pancreas staging, grossing, and have some case-based examples coming up. So let's begin. Majority of the specimens that we receive in the gross room are actually minority of the patients with pancreatic cancers, because whenever a patient is diagnosed with the pancreatic neoplasm, um, i often the disease is significant enough that they will not go for a resection. But so it's actually quite minority of patients are medically able to go to tolerate a resection. The way that one of the indications for which surgeries determine whether or not a patient is going to go a resection or is not is how much of the tumor is encompassing the superior mesenteric artery, for example, or superior or mesenteric vein (SMV). Um, and this is important because if the neoplasm, which is shown over here by this enhancing nodules in the pancreas is right there, is not encasing the vasculature, it can be resected. If the neoplasm is abutting the vasculature, this is a marginally but borderline resectable, but it's involving less than 180 degrees, so it can be resected. But if the neoplasm is completely encompassing the vasculature over here, it's unfortunately it cannot be resected. So when a patient is able to proceed with a Whipple, there are the stages of Whipple. There's six basic stages, but really the only reason this picture is here is to show you that in a Whipple, this is where the margins happen. You have a bile duct margin, a stomach margin, which is a proximal margin, a distal margin, which is a duodenum, and then the pancreatic resection margin, and also the uncinate margin, which is not shown here. And uncinate, oh sorry, and then after the reconstruction, this is what the anatomy looks like. Stomach is connecting to the jejunum, and liver and bile duct, and the pancreas is also connected to the jejunum. So here's a more complex an example of the anatomy. Really, the only reason this is here is again to illustrate the margins. Here is the distal margin, the proximal margin, the pancreatic resection margin. The bile duct margin is somewhere over here, and then the uncinate margin is hiding over here, and here is the tumor. The uncinate margin is important and can be confusing, but that is the uncinate truly translates to the hook. It means the hook, and the tumor. It's a part where the tumor or the pancreas is very close to the vasculature. It's kind of wrapping around the vasculature, and the significance of the uncinate margin can be demonstrated here because here, if the disease burden is very high, you could see that the tumor can potentially involve the vasculature, and this could be a potential positive margin. So when we take our margins from a Whipple, it's actually very easy because we take the bile duct margin, the proximal margin, which is the stomach or potentially the duodenum, and then the distal margin, which is again the duodenum, the pancreatic resection margin. And keep a note, all of these margins are taken en face. They can be taken fresh right when the specimen arrives, and then we take the uncinate margin, which is hiding right over here perpendicularly. Then we open up the duodenum, and then we bivalve the pancreas when we have two probes, one in the bile duct and one in the pancreatic duct. And we get this really nice specimen, and then we let it fix overnight, and we take our sections the following day or later in the day, whichever is better for you. So here's what it looks like. I got this from the Chicago Grossing Manual website. That's very good. You could see here you have the distal stomach margin, the proximal stomach margin, distal duodenum margin, the vascular SMA groove over here, pancreatic neck margin again, and the uncinate margin. And sometimes the gallbladder can be received whole. So I guess in that case you don't really have a biliary, like a bile duct. No, I think you would still have it. No, I'm actually not quite sure because I have never received a Whipple with a gallbladder attached. But I'm assuming if you don't have a bile duct, that was cut, you technically don't have that margin there. So you'd only have, I guess, four margins in this case. But generally there are five. And great, now that you received this Whipple and you have to like write up this case and diagnose this case, there's actually four different staging summaries depending on the type of tumor that is there and the location of the tumor. Majority, like when we think of pancreatic adenocarcinoma, we're thinking of exocrine pancreas, which is the staging summary is right here. When it's a neuroendocrine tumor or endocrine pancreas, we're thinking about this staging summary. But the tumor site can also be common bile duct, which is extrahepatic or extra pancreatic or intrapancreatic, or it can be the ampulla of water, which is that little papilla, and there's different variations here. Now, the question is, how do you tell? Very easy. You refer to a picture like this or similar, or you can also refer to the Christina Arnold Atlas of GI Pathology. If your tumor arises in A, it stages a duodenal primary. If it arises in a C, it's staged as a pancreatic primary. And if it arises past the bifurcation of the ampulla of water, and then past this bifurcation, it occurs, it's staged as an extrahepatic bile duct primary, which is right over here, distal extrahepatic bile duct. And then it gets even more granular. If the tumor, how do you determine if it's like in the duodenum or the ampulla, and if it's in the ampulla, what part of the ampulla? So if it's here and it's in the D, it's in the duodenum. But if it's in the A, it means it arises on the duodenal surface of the papilla, so it's periampullary type. If it arises within the ampulla right here, it's ampullary type. And keep in mind, the ampulla area is right when after the confluence of the distal bile duct and the distal pancreatic duct occurs. So it's just this area over here. And C, when it arises like over here, it could be the intraampullary and periampullary region. And here you have to specify all of that. The way you determine this is that you find the epicenter of the tumor and you stage it based on the epicenter where the main tumor mass occurs. And this can be tricky, but this is beyond the scope of this talk. So with that being said, let's talk about our first case. This is an adult. They underwent a Whipple, and we're seeing here a large piece of duodenum, so potentially duodenum. There's two staple margins, no stomach over here. Doesn't seem like there's any stomach here. And there's this really hemorrhagic mass over here. You could see it with serially sectioned, tons of hemorrhage. So what could this be? This is actually what a transplant pancreas with adjacent small bowel anastomosis shows. This is probably a patient who unfortunately had their pancreatic transplant fail, and you could see that this pancreas has a ton of necrosis, ton of hemorrhage, and this is what it looks like grossly. There's actually no viable pancreatic tissue present, and because this presentation is called the nuts and bolts of the pancreas and staging and so on, we have random pictures of hardware. And how do you gross this hardware, and how do you describe it, and how do you sign it out? So here, you would look at this hardware, you try to find any serial numbers, and then you'll mention the serial numbers here, and then you sign it out with a one-liner, metallic hardware, gross examination only. Great, let's do next case. So this is a cystic 3.2 centimeter pancreatic head lesion. You can see that this specimen is inked, with yellow being the pancreatic duct and green being the common bile duct. And then there's a cystic kind of a mucoid-like lesion. So the thing that when it's a mucoid kind of type of lesion like this, it could be a mucinous neoplasm. And then here on histology, you would look for like ovarian stroma, and then you would look for dysplasia if it's present. So here, the way that you would sample this is really straightforward. In green, you could see that the margins are highlighted, and then you describe the lesion, and then you measure the lesion relative to all the margins. So really, this is standard. This is all pretty standard, but then you really just want to describe the lesion and measure it relative to all the margins. And then this is signed out as a mucinous epithelial line cyst of the pancreatic head, compatible with intraductal papillary mucinous neoplasm. You talk about the margins, you talk about whether there's dysplasia or not, you talk about lymph nodes, and then in this case, actually, it's really interesting. There was not much ovarian stroma, so this it's not really a mucinous cystic neoplasm. This could potentially be a simple mucinous cyst. So for the patient, this is great news. They do not have cancer. Next case, we have again a bunch of hardware. You look for serial numbers. You describe it, and then you take some measurements. In this case, this was I don't think there was any serial numbers on this hardware, so this was just described as explanted hardware and measured in aggregate, and this was signed out as explanted hardware, gross only. Here we have another specimen. This is another Whipple. You could see here is some duodenum, here's potentially stomach, and here's a really large mass When this is inked, you could see the red is Oncinate margin, black is vascular groove, blue right here. I think this is some blue over here. That's pancreatic neck resection margin over here. It looks like it, and then green. I don't really see green here. It must be on the other side. When this is bivalved, you can see green is the common bile duct and the bile duct margin, and you can see there's this very serous, multiloculated cyst-like area. Sorry, not a cyst, multiloculated chyli lesion with tiny little septated areas, and there's a huge scar through the middle as well. So this was gross. Again, this was described as a microcystic lesion. The margins were sampled, and then this was signed out as a serous cyst adenoma measuring almost 11 centimeters. And then you talk about lymph nodes, and you talk about some background pancreas, and then talk about the duodenum and the stomach. Cool. More hardware. This looks like orthopedic hardware again. You would look at this, you would describe it, and then you would sign this out. So this was described by a lot of words. There's a lot of words here. There's gross photographs. There's lots of length and measurements taken. And wow, this was signed out with a one line as a orthopedic hardware, gross only. Like just wow. So much text to so little text. It's quite amazing. And then, so we have another another Whipple specimen here. You could see here's a portion of the duodenum. I think it looks like it's been potentially opened or received disrupted. I'm not quite sure. Or maybe the picture was taken after it's been partially opened. Maybe here's some stomach over here. And here you could see it's probed through the bile duct and then the pancreatic duct as well. And right over here on the close-up, you could see that the ampulla of water is obstructed by this massive polypoid lesion. What could this be? So could this be this cancer, or is this just a large tubular adenoma? Here's another example. You could see it's inked with green being the bile duct. Orange, I think, was the pancreatic duct. And here's a massive polypoid lesion. This was actually sent for a frozen, and it's actually really interesting because, again, this was sent by for a frozen. This was called as margins grossly negative. It's actually is a gross only consultation. And again, when it is submitted, you submit it based on having all the margins, and then the representatives, and then you submit some of the lesion. And this was actually really interesting because this was signed out as a tubulovillous adenoma, 5 centimeters in greatest dimension, and resection margins were negative, and the lymph nodes were negative. So very interesting case. And here, not hardware, but again, kind of random stuff that you can receive in the gross room. Here is a heart valve. How do you gross a heart valve? What do you actually do with it? So you gross it by describing it. You try to take some tissue if you can. If there's any gritty tissue that you can take off, and then you submit it, and then you basically describe it as explanted bioprostatic cardiac valve with calcifications and some calcified annular tissue. Inflammation is seen. Cool. Okay, here's a next case. Right over here you have the Whipple, you have stomach, you have a stented bile duct, you have potentially what is like the ampulla of water over here. So here they're not connecting. And then over here you could see this a portion of duodenum, and it doesn't look great. It looks almost like ischemic. So here you go. Look at this. This was inked, and green is the bile duct. You can see it's stented, and yellow is the pancreatic duct. And if you look closely, you have the lesion over here. Yeah, it looks kind of polypoidy. What could this be? Is this another tubular adenoma? And here's another better picture. Here's the mass over here. It's obstructing the common bile duct. And yeah, so again, here we go. This is what it looks like. With this mass was described as a periampular duodenal polypoid white-tan firm rubbery mass. And then it was the specimens were submitted as follows, where you have all your margins, and you sample the lesion, you submit it entirely relative to all the bile duct and the pancreatic duct. You submit representative sections and lymph nodes. So how do we what staging system are we actually using for this? Because this was called mucinous adenocarcinoma of the ampullary duodenum, moderately differentiated, and the carcinoma invades deeply into the duodenal wall. And then the resection margins are negative, and then metastatic carcinomas involving actually several lymph nodes. So we use the ampullary staging summary for this. And as you could see, in this case, the tumor invades into the muscularis propria of the duodenum. So this was staged as a PT2 and a PN1. So here's the final diagnosis, and this is ampullary. This was actually a tumor site is ampullary duodenum, and stages of PT2 and 1, and it invades deeply into the duodenal wall. And then we have another picture of hardware. This looks like, again, some orthopedic hardware. It was described by, you talk about the different serial numbers, and you mentioned those. You take measurements, and again, it's signed out as one liner: orthopedic hardware, gross only. Boom, next case. And then here we have another specimen, very interesting specimen too. Here is it's bivalved. You could see here is the neoplasm right over here, and then here is what appears to be duodenum, and then here maybe some of the stomach. And then let's take a closer look. You could see that this neoplasm is kind of well circumscribed. It has a capsule potentially, but it looks like it's multiloculated or inseptated, and it's also pretty hemorrhagic inside, and maybe it's quite necrotic as well. So here's another closer look at it again. And then, so what's the stage? So this was called solid pseudopapillary neoplasm in an adult. So they can occur in adults. They're mostly the solid pseudopapillary neoplasms occur in pediatric populations more frequently, but they can also happen in adults. So this was called solid pseudopapillary neoplasm. What staging system do we use for this case? We use the pancreatic exocrine staging summary. And here, this tumor is greater than 4 centimeters in greatest dimension. It is a stage of PT3, PN2. Actually, wait. Sorry, this is actually supposed to be a PN0. This is a mistake. There's no lymph nodes that are positive in this case. Sorry about this. Is a mistake. So, again, this was signed out as a solid pseudopapillary neoplasm, and you would order a beta catenin CD10 to see because this should have the lesional cells should have nuclear positivity for beta catenin. And great, so this is how the specimen was signed out. Great, and then we have another case over here. We have a Whipple. It's been opened. We have the duodenum. It's over here. We have some distal stomach, and you can see that the ampulla of water is probed. And here again, it's inked with distal margin orange, proximal margin red. Kind of see some red over here. Black is the uncinate margin shown over here. Pancreatic neck margin is yellow. Kind of hard to see maybe over here. And then we have green is the bile duct margin. So when it's opened up, it's a lot easier to see that here's the bile duct margin, here's the pancreatic margin, and here is what potentially looks like our mass. It doesn't look like normal pancreas. It looks like more like a solid area. So this again was sampled as follows. It's important all the margins are sampled first, and then the specimen is sectioned to reveal an ill-defined firm Y10 mass in the pancreas abutting the uncinate and the pancreatic neck margins. So it's pretty, and then you measure it roughly from all the margins, and then you to document that, and then you take pictures. And then, so this was actually an infiltrating adenocarcinoma, moderately differentiated, invading into the duodenal wall and ampulla. So how do we stage this? This was staged as, I think this was actually staged using the exocrine pancreatic staging summary. And here we have PN2 because it's 4 or more regional lymph nodes. Here it's 5, and it's PT3 because it's 5 centimeters in greatest dimension. And here's how it was signed out. It was a PT3, PN2, and it was an adenocarcinoma. It was staged using a pancreatic exocrine summary, and this was how it was signed out. And here it's important, this is why we sampled the uncinate margin, because the tumor was present less than 1 millimeter from the uncinate margin. And then finally, last but not least, is an example of how we would gross a pacemaker with leads. This is what it looks like when we receive it in the grosser material. It's a bunch of hardware, a bunch of wires, and then you take pictures of it. You look at you have to take a lot of pictures for something like this, and then you take essentially all the pictures. You document all the hardware, all the serial numbers, take a lot of pictures, and again, it is signed out as one liner gross examination only. And I hope that was educational. Thank you for watching. And don't forget to like and subscribe, because when you like and subscribe, it helps other people find this video and find this channel. Thank you.